Welcome to the third session where we deal with how to do target trial emulation. As seen in the first session, there are essential decisions that we need to make when it comes to clinical practice or in public health situations where we tend to compare between effectiveness and safety of treatment A compared to treatment D, or when we try to compare one particular community-based intervention like a screening program, whether it works in the real world or not. Essentially, which are causal questions. Ideally, we would like to control an RCT, conduct an RCT to inform our decisions, but not always possible because maybe too expensive, not timely enough, just not feasible, or just simply unethical. So, in an alternative approach, we rely on analyzing observational data. Let us imagine a hypothetical trial that we would like to prefer to conduct and then analyze using a causal inference approach in an attempt to emulate that particular target trial. In a simple two-step algorithm, we would like to ask the causal question, that is, specify the protocol of the target trial explicitly and then answer the causal question by conducting the trial or emulating the trial using observational data. Deviations from the target trial can lead to bias. That is why we need to explicitly state the protocol of that proposed target trial and then analyzed based on the protocol. Let us look at the components of a target trial protocol. The eligibility criteria of the intended target trial remains the same as the RCT that we would like to conduct. In this example, the prostate cancer screening with prostate-specific antigen test and the prostate cancer mortality, in which the eligibility criteria starts with saying that we want to conduct the study among men aged between 55 to 74 years between these years from a particular stated residential area who are users of a particular health system in the past year with no obvious previous history of cancer, prostatectomy, or more than one PSA test in the past 3 years. The same eligibility criteria can be applied to the target trial. The participant should be eligible to receive all the treatment strategies of interest. The treatment strategies under consideration are two different strategies. One is the screening group, which has an annual PSA testing for 6 years, and the no screening group, which is categorized under the usual care or standard of care. The same two treatment strategies can be carried over to the target trial emulation. Thereby, we need essential subject matter knowledge which are needed to identify strategies that are relevant to this particular causal question. These two strategies can be done by using randomization in the target trial. But in the emulation, it has to be equated by using baseline confounders such as age, race, and body mass index, thereby assuming randomization. To adjust for confounders is to emulate random assignment. Since random assignment is just not possible in an observation study, the alternate is instrumental variable methods. By using any number of methods for adjust for confounders, we try to emulate random assignment in a target trial emulation. And for follow-up, from randomization until first occurrence of either development of outcome, death, or loss to follow-up, 10 years after baseline and end of study period. The same outcomes can be carried over to the target trial emulation and can be explicitly stated. One of the important things to consider under this particular area is the need to alignment at time zero, where the eligibility assessment, the treatment assignment, and start of outcome assignment has to be very clearly spelled out. Otherwise, immortal time bias or selection bias is bound to happen. Outcomes which are specifically stated in the target trial is prostate cancer specific mortality, which is the same as in the target trial emulation. The causal contrast is established by analyzing as per both the intention to treat effect and the per protocol effect. The same is carried over in the target trial emulation as well. The data analysis can be done using inverse probability weighted pooled logistic regression models, which is the same method that we would like to conduct this target trial emulation. And subgroup analysis can be done using the age and race. This particular approach where we use target trial protocol and then analyze the observational data, we are bound to fail under certain conditions. Lack of randomized assignment, which can be addressed using adjusting your confounders. That is essential for making sure there is randomized assignment. Often, the time zero is misspecified. The target-trial approach allows you to articulate these trade-offs that you are willing to accept in your observational analysis. And we analyze observational data not necessarily because we essentially want to. In general, we can only emulate pragmatic trials where no placebo control is possible. At most, we can compare against standard of care. No blinding is possible. Treatment strategies must exist in the real world because unreal treatment strategies cannot be compared with. And no tight monitoring and enforcement of adherence can be mandated in real world conditions. And what does successful specification of emulation essentially require? It first requires a subject matter knowledge of what treatment strategies are relevant to this particular causal question, to answer this causal question. And what are the potential confounders that we should be concerned about? We also require high quality data on treatment, outcome, and potential confounders. Of course, there will be unmeasured confounders which will eventually play their role, but as much as possible, we need to have data on all relevant confounders. Knowledgeable users of data. How are these data collected? And how to extract relevant information from these complex databases is an essential knowledge that we require to conduct a target trial of this magnitude. And of course, we need to be aware of the appropriate causal inference analytics, whether G estimation or inverse probability matching or any number of causal inference techniques which are available to us. These are very essential for us to conduct a target trial emulation. Thank you.